I want to begin this lecture with explaining that this course will cover a total of 52 conditions. You will find the list of conditions in the syllabus folder. Some of the conditions fit nicely in a group and some do not. I have made an effort to present the material in an organized fashion, but sometimes some modules will just have random conditions that really don't relate to each other. Abnormal movements. Movement disorders are classified as hypokinetic or hyperkinetic. Hypokinetic abnormal movements are decreased or slower than normal, purposeful, voluntary movements. The only hypokinetic abnormal movement we will cover in this course is bradykinesia. We'll see bradykinesia type abnormal movements with Parkinson's disease and multiple sclerosis. Hyperkinetic abnormal movements are increased involuntary movements such as tremors seen in Parkinson's and myoclonus with restless leg syndrome, dystonia in Wilson's and also Parkinson's. Chorea is a hyperkinetic abnormal movement associated with Huntington's disease, hemibolismus, and some cerebral palsies. Athetosis is also seen with Huntington's disease and some cerebral palsies and is often combined with chorea. Chorea, hemibolismus, and athetosis are all a result of overactivity of the basal ganglia. Finally, there are tics. The only abnormal tics we cover are associated with Tourette's syndrome. Tremors are the most common kinetic abnormal movement disorders. Tremors involve involuntary rhythmic muscle contractions leading to shaking movements of one or more body parts. The tremor itself is not life-threatening. However, they can become disabling and conditions associated with tremors may be life-threatening. An interesting fact is that tremors stop completely when the affected person is in a deep sleep. And, to no surprise, tremors increase with emotional stress. Many conditions can cause tremors, such as neurodegenerative diseases, brain injury, stroke, multiple sclerosis, hyperthyroidism, and withdrawal from drug or alcohol addictions. Some tremors, as in the case of essential tremors, the cause is completely unknown or idiopathic. Resting tremors only occur when muscles are relaxed and at rest. They can occur in the hands, arms, and legs. They may only affect one body part, such as the hand, which is the most common location of a resting tremor, but they can also affect the arms and legs, in some cases all three. Interestingly enough, these tremors will temporarily go away when the affected person engages the muscle of that body part. For example, a unilateral hand tremor in Parkinson's patient will stop when they try to grab their water bottle. Action tremors are the opposite of resting tremors in that they only occur during voluntary movement. An action tremor can occur with any voluntary movement such as flexion and extension of the wrist or opening and closing the eyes or grabbing the handle of a coffee cup. An intention tremor is a subclassification of an action tremor. Intention tremors occur with visually guided purposeful movement toward a target, such as the finger-to-nose neurological exam. Action tremors are seen with multiple sclerosis or any other cerebellar condition. Essential tremors are the most common type of tremor. The degree of shaking differs from person to person. In some people, the tremor is so slight that it's hardly noticeable and does not interfere with activities of daily living. However, some people shake so violently that it even affects their ability to hold a pen or a pencil so they can write, or to hold a toothbrush so they can brush their teeth. These tremors are typically bilateral, but would be more noticeable on the dominant side. If the tremor affected the head, it usually causes a yes, yes, or no, no type shake of the head. People can manifest this type of tremor at any age, but the typical age range is between the ages of 40 to 50 years old. And about 50% of people with this condition, the cause is unknown, aka idiopathic, and about 50% have a familial genetic association. Children with an affected parent may develop this tremor earlier in life. Athetosis is slow, writhing movements typically affecting the hands and feet. If the affected person holds one limb with another limb, it produces a continuous flowing stream of movement of the trunk. Hands can present dystonia-like features in the digits along with the writhing of the hands. See how the diagram represents the fingers in extension? When athetosis occurs with chorea, and it often does, it is called choreathetosis. The movements with choreathetosis are slower than in regular chorea alone, and more dance-like, but faster than just athetosis by itself. We will see this movement disorder in Huntington's disease and certain types of cerebral palsy. Dystonia is a movement disorder in which muscles contract involuntarily, causing repetitive or twisting movements. Think of dystonia as a super muscle spasm. Sometimes this muscle spasm is so strong that it prevents movement. The example in the images show dystonia of an elderly woman's foot with fixed inversion and one showing lateral flexion of a baby's neck, representing torticollis. Dystonia can be mild to extremely painful and can limit function. The key word or symptom in separating dystonia from a mild muscle spasm is twisting. Dystonia muscle spasms are so strong they cause twisting of a body part. We will see this abnormal movement in Parkinson's disease, Wilson's disease, multiple sclerosis, cerebral palsy, and sometimes with stroke. Rigidity. Muscle rigidity is abnormally tight muscles. It doesn't cause flexion contracture or twisting contracture as in dystonia. It can, however, limit both passive and active range of motion. Muscle rigidity can be an early underlying symptom leading to bradykinesia and dystonia in Parkinson's disease. Muscle rigidity is often associated with subluxations. Locating muscle rigidity with palpation can be a useful tool in establishing the chiropractic patient's subluxation pattern. Hemibolismus is a type of unilateral chorea affecting only one extremity. It can be either an arm or a leg, but the arm is the most common limb affected by this condition. Hemibolismus is an involuntary, violent flinging of one extremity. Flinging actually means ballistic, and that's how it got its name. Movements are wider and more intense than bilateral chorea. Hemibolismus is typically self-resolving and can last from several days to 6 weeks. Antipsychotic drugs help to suppress the flinging movement associated with hemibolismus. The most common cause of hemibolismus is a small lacunar infarct of the subthalamic nucleus. Symptoms will manifest on the opposite side of occlusion. In this diagram or the MRI image, you'll see the circles are showing the lacunae that are associated with this infarct. A lacunar infarct, or ischemic stroke, occurs when one of the arteries that provide blood to the brain's deep structures is blocked. These arteries are small and vulnerable to continuous pounding of blood against their walls caused by chronic high blood pressure. Chronic high blood pressure leads to scarring of the endothelium, which can eventually lead to atherosclerosis. It is the atherosclerosis that occludes blood supply to the subthalamic nucleus and other deep tissues. Diminished blood supply to tissues will cause tissue death. In this case, the tissue death creates little cavities in the subthalamic nucleus called lacunae, hence the name lacunar infarct. Myoclonus is a sudden involuntary jerking of a muscle or group of muscles. Myoclonic twitches or jerks are non-suppressible and are sometimes associated with a shock-like sensation. Hiccups are a form of a sudden, non-suppressible sudden muscle jerk. Restless leg syndrome is a type of sensory motor disorder that causes nocturnal myoclonus. Restless leg syndrome can affect all extremities, but it most commonly affects the lower extremities. The muscle twitches or jerks associated with restless leg syndrome have an attendant shock-like sensation preceding the involuntary muscle contraction. Tics are rapid, repetitive twitch-like uncontrollable involuntary movements. They are typically preceded by a strong urge to do the tick, followed by a brief sensation of relief after doing the tick. Tics are not painful and are not associated with paresthesia. A person with tics can briefly suppress them, but it takes deliberate, exhausting conscious effort, and eventually the urge of the tic will overcome the effort to suppress it. Tourette's syndrome is a condition of the nervous system. As of yet, the cause is still unknown. The symptoms of Tourette's is involuntary tics. There are two types of tics associated with Tourette's syndrome: motor tics and vocal tics. Motor tics can involve rapid blinking, shrugging shoulders, jerking of the arms, and many more types of tics. Vocal tics can involve humming, repetitive clearing of the throat, inappropriate yelling, just to name a few. Tourette's syndrome typically begins between the ages of 5 and 18. The symptoms, which are only tics, may be chronic and carry on into adulthood, or they may dissipate in adulthood. There is no lab diagnosis for this condition, so diagnosis is clinical only, meaning the doctor or therapist has observed motor and vocal tics in the individual for at least 1 year. Tourette's syndrome often occurs in children who are also associated with ADHD and OCD.